Okay, well, hello from Arkansas. I'm Jamie Watson with the University of Arkansas for Medical Sciences. Thank you all for your interest in my talk. I want to thank the IHA for an excellent conference. I've learned a lot and for allowing me the opportunity to present today. And thanks to the technical team who've made this process very smooth. I think despite all of the little technical glitches that have happened along the way, the technical team has really been very helpful and appreciate all the support they've given us. My path into health literacy is through ethics. So I'm part of the Department of Medical Humanities and Bioethics at UAMS, the University of Arkansas for Medical Sciences. And I'm also a clinical ethicist. And if you're not familiar with what clinical ethicists do, I'm part of a 24/7, 365-day a year clinical consult service. So we meet with providers and families and patients to deal with to help with difficult cases. For example, requests for inappropriate treatment, identifying appropriate surrogates, setting goals in complex cases, care plans, helping with decision making for minors, especially teenagers, that sort of thing. We write chart notes, so we're part of the clinical team. But I had the benefit of working with UAMS's Center for Health Literacy with my colleagues, Allison Caballero, Katie Leith, and Maria Ruvalcaba for 2 years, learning how to write plain language and editing our documents. I'm really proud of some of the work that we've done through the Center for Health Literacy. But one of the things that was very clear to me early on was how much overlap there was between health literacy interventions and the work that I do as an ethicist. So for example, in cases where we meet with families, it's very important to be familiar with health literacy practices, best practices for oral communication. For example, teach back and chunking information. So when I'm meeting with providers before we go into a family meeting, several of the things that I talk with them about are, what are the goals for the meeting? So making sure that the purpose is clear up front. Reminding them to speak in chunks, so 1 or 2 to 3 ideas at a time, and then engaging with them and teach back. So that's been very helpful. But also the written strategies for plain language has been very helpful in my work as an ethicist. For example, writing policies, especially patient-facing policies, such as our patient rights and responsibilities information. And also one of the things that I think our center is most proud of is the work we've done on our informed consents in the hospitals. We have an informed consent template that's available to any researcher at the University of Arkansas for Medical Sciences and is often recommended by our IRB. And it's vetted for plain language best practices. It's not always possible for them to use it. Sometimes industry has their own informed consent that we can't use. But I'm very proud of the work that we've done with the informed consent. And so today I want to talk about health literacy ethics in public health emergencies. And my goals here, I can get my PowerPoint to work. I distinguish public health ethics from individual, or what we might call bedside ethics, and explain 3 ethical challenges to effective communication in public health emergencies. I highlight some distinct challenges posed by the COVID-19 pandemic. And I'm going to highlight some typical health literacy strategies for addressing these challenges, but I'm going to offer 3 suggestions for how to combine these with public health ethics to enhance communication during public health emergencies. So I think one of the most important things to start with is sort of what it means to engage in public health ethics and how that might differ from more traditional orientations in ethics, sort of individual ethics or bedside ethics. And to start, I want to talk about what I mean by public health emergencies. A public health emergency is sort of it's a legal term that differs from state to state. But what I'm going to mean is an event that poses an immediate health threat to an entire population, and how that population is determined is going to differ depending on the public health emergency, the event in question. But examples include things like Hurricane Katrina and Hurricane Sandy, oil and chemical spills, bioterror threats, and viruses such as SARS, Ebola, and now COVID-19. Some people include the opioid abuse as a public health emergency. But when we're facing public health emergencies, there's a shift in orientation in medicine from what we might call traditional medicine to public health medicine. And the shift is defined in 4 different domains. One is the object of concern. So with traditional medicine, we're concerned with the individual at the bedside, the individual who presents to us in the clinic or the hospital or in the doctor's office, where we're trying to meet their needs. Whereas in a public health emergency, we're looking at population's needs, the needs that, that the event, whatever public health emergency has placed on the particular population. The primary health goal shifts from being primarily about treatment and cure to primarily about prevention. These, in no case, are treatment and cure not a priority or prevention not a priority. Obviously, in traditional medicine, we're very concerned about prevention. But prevention looks different in traditional settings versus public health emergency settings, and the priority shifts from treatment and cure of individuals to helping populations prevent the worst effects of a public health emergency. The locus of authority shifts, and this is where we get some concerns about individual rights and state interventions. But the locus of authority in traditional medicine is on the individual. The individual, when they're capacitated, they have the legal and moral right to make decisions for themselves, whether to consent to or refuse medical interventions. But in public health emergencies, the primary orientation shifts to the government or state agency and what role they play in either disseminating information or restricting certain kinds of behaviors. And the health orientation shifts from maximizing autonomy of the patient, engaging with the patient about the goals of care that are best for them, which may include refusing treatments that medical providers think are appropriate, to maximizing benefit. And if you've read any of the literature on triage policies during pandemic conditions, they include things like saving the most lives. So we're trying to maximize benefit under conditions of scarce resources. And so one of the big concerns with public health ethics, of course, is scarce resources, whether that has to do with ventilator scarcity or PPE scarcity or bed scarcity or personnel scarcity, and how we balance those against medicine's traditional commitment to individuals and treating and curing individual health problems. And the maximizing of benefit is important to note that it's about different types of populations. So obviously medicine during public health emergencies has a commitment to benefiting all populations, the entire population. But this can also be reflected in subsets of the population. For example, particular minority groups that might be especially negatively affected by the effects of a public health emergency. And because of this shift in orientation, this shift from medicine's traditional orientation to public health orientation, people get concerned about how they're going to be taken care of by the medical community. And so one of the things that public health officials owe individuals under those circumstances are additional ethical considerations that include trust, transparency, and equity. So when we're shifting orientations, people get worried about, well, am I going to be taken care of? If I have a disability and there's a triage program, triage protocol that's been enacted by my local hospital, am I going to be disproportionately disaffected by that because I have a disability? Am I not going to be able to access the care that I would typically get if this weren't a public health emergency? And how might medicine address that? And so what I want to do is have a couple of interactive moments in this. So I would like for you all, I've highlighted 3, and these are the 3 that I'm going to talk about in this presentation: trust, transparency, and equity. But those of you who've had contact with public health ethicists or public health medicine in general, what additional ethical considerations might public health officials owe to populations in times of public health emergencies? So if you would, use the Q&A. I'd love to chat with you about what sorts of other obligations. Access to information, that's right. Truth, yeah, it's an important one. Thank you. Cultural concerns, absolutely. Timely, time is going to matter a lot during public health emergencies. Sorry, that was not an intentional thing. End of life concerns, absolutely. Privacy, Enhanced resources for more affected groups. Confidentiality. Yes, privacy is a big concern when you get into public health, right? If we're doing contact tracing, what does that mean for individuals we're tracing as far as their health information goes? Information they can understand, facts. The language is available. Yeah, I'm going to talk about that. Authority. Who's in control in my medical decisions? Prompt and full info ASAP is available. Yeah, thank you. We're going to talk a little bit about time and its role in public health ethics. Empathy. Absolutely. Yeah, something brought out in the earlier presentation this week on by Communicate Health about the role of empathy in health communication. Inclusivity, communication barriers. Thank you. Thank you all for your participation. This is great. Religious beliefs. Absolutely. If someone else is making the medical decision, if the locus of authority is shifting to the government, what does that mean for people who have religious beliefs that might be implicated in some of the decisions made? Cost and expense, access to resources. Absolutely. Thank you. I can't list all these because I want to move on, but thank you very much for participating. Yes, absolutely. And there are a number that are listed in the public health ethics literature, including accountability to government organizations who are making decisions that affect populations as a whole and individuals, that the fact that they're evidence-based, that they're appropriately responsive, that they're proportionate, that sort of thing. But I'm going to focus on trust, transparency, and equity in this process. So what are some ethical challenges to effective communication in public health ethics? So the one question might be, where does the ethical obligation stem from? And I think it stems from the responsibility medicine has to the community. Medicine is entrusted with our health, and as that orientation shifts, there are questions that arise as to how the responsibility to caring for our health, the people we entrust with our lives when we're making complex medical decisions, how that responsibility changes as we move into public health emergency situations. And so I want to highlight 3 types of ethical challenges for effective communication in public health emergencies. One is time. The public needs information fast during public health emergencies. The situation is changing quickly. They need information about what they need information about the event itself. They need information about how to act in response to the event. And they need information about the services they have access to during the event. If there's a shortage of beds, they need to know that, and they need to know what their recourse is. And so this refers to our ethical commitment to benefiting our populations through trust, making sure that we're getting information to them in a timely manner. There's uncertainty in public health emergencies. In many cases, experts themselves aren't sure how to respond because they're still learning a lot about what's happening on the ground, whether it's a hurricane or a new virus. And so experts have an obligation to distribute information responsibly. So not distributing information too quickly before we have consensus about what that information means for the population, because one of the things we don't want to happen is we put out information too quickly. That information turns out to be bad information because we just didn't have enough evidence yet. Not enough people had reviewed it or looked at it. And that information turns out to be bad information. And we lose trust with the communities that we have been commissioned to benefit. And so we've got issues of transparency and trust when it comes to uncertainty in public health emergencies. And of course, we have issues of inequity when it comes to public health emergencies. Existing disparities are exacerbated when these events arise, which means that the negative impact on some populations will be worse than others. And this heightens the medical community's responsibility to know which populations are going to be disproportionately affected and to take steps to mitigate the worst effects of the public health emergency on them. So what I want to do is turn it over to you again for a little interactive engagement. What ethical concerns related to time, uncertainty, and inequity have you recognized or identified or noticed with COVID-19? So again, use the Q&A function and tell me some of the things. Uncertainty with masks, absolutely. I already got one, masks, right? Because there's been a shift in the advice regarding masks from the beginning of the pandemic until now. Now we seem to have a fairly wide consensus about the importance of masks and how to use them and their benefit to the population. But early on, there was a lot of scrambling to figure out what the benefit, or if there was a benefit to wearing masks in public. So I appreciate that. Too much jargon, absolutely, right? Well, this is an information issue. The experts in this field are experts because they have a grasp of jargon that the rest of the population doesn't. And so we have an obligation to make sure that jargon is getting translated appropriately throughout the process. Knowing who to believe, who's a real expert, who isn't, absolutely. Food supply, big concern, right? When we're concerned about essential workers and who gets, which industries are suspended during the public health emergency and which industries aren't. Misinformation disseminated from governmental sources. Yeah, big concern, right? This is an issue with uncertainty. When governmental sources, the people that are supposed to be trustworthy, are putting out information too quickly before there's a consensus or before there's enough evidence to make a judgment about such things. Wealthier people are able to get tested ASAP, and this is an inequities concern. People with resources may have access to health services that other people don't, and that's a big inequity problem. Again, we have issues of trust, we have issues of transparency, untruths, delay in information and guidance, information on how it's spread. If you require people to wear masks, provide them for people. It's a great point. So the advice we give should be followed up with some sort of action. Is the virus airborne or not? Again, questions about our understanding of experts as we gain new information. The cost of testing in healthcare, right? I'm not going to go get tested if I'm afraid that it's going to bankrupt me. CDC used to give info, not the HHS. So goodwill was lost. Uncertainty about how to correctly distance, right? So the accuracy of information. Thank you very much. These are great comments. Response to treatment. Traditional channels may not reach vulnerable populations. As we've seen in this conference, we heard in this conference, there's a certain large percentage of the population, especially those who are at high risk of struggling with health literacy, who don't have access to the internet. Absolutely. All right, well, thank you for your responses on that. I'll give you some of mine now. So with respect to time, medical resources are depleting quickly during a pandemic. And this doesn't necessarily mean ventilators. Early on, it was ventilators. The ventilator question has sort of dropped out as we've addressed some of those issues. But there are other issues of resource depletion that haven't been addressed and aren't as publicly acknowledged, such as PPE or resources, personnel or beds. So the public needs to know how the medical community is handling the depletion of resources, which resources are in need and how they're handling it. The morbidity and mortality rate, the effects of this illness on a significant portion of the population are severe. So the public, many segments of the population are afraid and they want info to be able to protect themselves. If the info isn't clear or if it's not detailed enough, they're gonna write it off. They're gonna say, this is not for me, this is not helpful. Maybe they don't want me to be helped. The spread of this virus is fast, and so the public's need for info is going to be time sensitive. Not only do we need to get info out quickly, we need to update that info quickly and make sure access to that info is updated quickly. Again, we've talked about the internet. If you have access to the internet, it's fairly easy to update information quickly. But are people coming back to those sources, or are they just downloading some PDF that you put out there 6 months ago or 2 months ago or 3 weeks ago that's been updated and they don't know that they need to be checking and continuing to access? And people who don't have access to the internet, are we going back to the community resources that we've partnered with to disseminate information to update it with them? And there's threats to livelihood, right? This automatically, when there's a threat to your livelihood based on either governmental restrictions or simply the fear of contracting and experiencing the effects of the virus, if it's going to affect your livelihood, then the public wants to know how you're going to handle that as a medical community? What are you doing to help guide public officials in the sorts of legislation or the sorts of policies or the sorts of advice that's going to preserve them? Because if they're concerned that there's a political motive to keep them out of the workforce or stop them working, or whatever the political motive might be, then you're going to sow distrust among the population that you're trying to help. With respect to uncertainty, absolutely masks. We've seen a trajectory in the consensus statements on masks over the past few months. The why questions are important to populations. Why 6 feet? I still don't think I've seen a clear explanation of why 6 feet and not 12 feet or 8 feet. Like, what's 6 feet? People need to buy in. We've talked about, we've seen in this conference, the importance of the health behavior model involves people buying into the information that you're giving them. And part of buying in is respecting them as people who can understand the information. And so the why matters. Why 6 feet? If I'm going to buy into the 6 feet requirement, then I need to understand what I'm buying into and why I think it would help me. There's misinformation and disinformation, as was brought up in the Q&A section. Do any drugs help? Right? What treatments have proved effective throughout the pandemic? Which ones have proved ineffective? And how are we communicating that? How are we addressing that concern? The questions about UV light that tended to be a sort of red herring in some cases. In some cases, it's relevant if we're talking about vitamin C deficiency, or sorry, vitamin D deficiency, but maybe less relevant with respect to treatments for or preventions against COVID-19. And so how are we addressing misinformation and disinformation? And what burden do health communicators face with correcting and redirecting people who are concerned about misinformation and disinformation, who are caught up maybe in a thread about them? And with respect to inequities, obviously, triage protocols have been hotly debated in some of the most prominent news outlets: Washington Post, New York Times, The Atlantic, the New Yorker. Triage protocols, there have been multiple lawsuits against states who have triage protocols on the books that either explicitly or implicitly discriminate on the basis of disability. And the question is, well, what is the medical community doing to address concerns from the people with disabilities? And what is the medical community doing to address concerns about those protocols that favor those with resources over those who don't? Many protocols, if not as a first line of decision making, but as a second or third tier of decision making, may include a first come first served tier. And to some populations that might be acceptable, and to some populations they may think, well, look, I don't have access to transportation, or my need might not seem as great to others, but it certainly is great to me. How do you address the concern about people with resources getting access to things like testing or services that others don't? Delays in translating material. So in Arkansas, I put delays in Spanish material specifically because here in Arkansas, it was many weeks after some of the first policies and procedures with respect to COVID-19 went into effect. It was many weeks before the state health department translated COVID-19 public-facing information into Spanish. And we also have a large Marshallese population in Arkansas. And the Marshallese populations and Hispanic populations are largest in Northwest Arkansas. And we saw our first hotspot outbreak of COVID-19 in the Northwest. There are a lot of questions about what was the cause of that. One of them could be related to the fact that they didn't have relevant information accessible to them in the language that they needed. And so these are ethical concerns about medicine's responsibility to the communities they serve. We have ample information now that COVID-19 disproportionately affects Black population and people over 65, which suggests, and we also know that certain minorities, the Black population and people over at least over 70, struggle with health literacy. And so we've got exacerbated inequities if we're not adequately addressing the information needs of these populations. So what are we doing about it? Well, interestingly, not a whole lot as far as our health communication goes. And I don't mean we as a health literacy community, but we as a broader medical community when we're producing public-facing health information. And so, for example, there was a study in 2017 by Kerr, Johnson, and Griffith on public-facing health information before COVID-19. What they found was on readability scores, they used 5 different readability formulas to assess about 70 documents. And they found only 1% of them was rated at 6th grade or lower. Everything else was in was either 7th grade or above. My colleagues at the Center for Health Literacy, Allison Caballero and Katie Leith and I, we studied 28 documents related to COVID-19, so from public-facing COVID-19 information. And what we found was only slightly better. So we found that 7% of public-facing health information was at the 6th grade level or lower. So we've not moved the needle much when it comes to presenting information to people who need that information during a public health emergency. Now, we use 3 readability formulas, and of course, one of the things that I recognize that has been mentioned many times in this conference, and I appreciate it because we believe that as well, that readability formulas are a good starting point. They're certainly not the be-all, end-all. They don't get to deep analyses of readability, understandability, actionability. And so, in addition to readability measures, we also applied the PMAT, that was mentioned earlier even today, the Patient Education Materials Assessment Tool for print materials. And if you're not familiar with this tool, the PMAT for print materials includes 17 items to assess understandability and 7 items to assess actionability of patient-facing health materials, and produces separate percentage scores for each area. And so using their PMAT user guidelines, we use 2 reviewers to independently assess materials and to reach scores. And that's how we came up with our analysis of public-facing COVID-19 information. And what we found in using the PMAT was noteworthy. So for example, even though, so there's some goods and there's some bad. Some strengths were that the materials didn't expect users to perform calculations. They presented numbers fairly clearly. They presented information in a logical fashion. Weaknesses were that the materials didn't include visual aids whenever they could make content more easily understood. Only 39% of the documents that we evaluated did that. The material did not use plain language. Only 46% did. Although some made their purpose completely evident, 58% made their purpose completely evident. And then medical terms, only 64% translated medical terms into plain language. And again, if you didn't hear, these slides are available in the handout section. With respect to actionability, although most documents did well with respect to the PMAT score of actionability, which means to identify at least one action users could take, unfortunately, in most cases, the action given was just to click to another website with more information. And in cases where it wasn't just clicking to a website, the actionable steps were vague. They did not address the user necessarily directly. So 61% broke down information into manageable steps. 64% addressed the user directly. So this is concerning. This is a failure of public health ethics, that we're not more adequately addressing public health information needs during a public health emergency. So public-facing health information that's difficult to access, understand, or use can make it hard for readers to protect themselves and those that they care about, which is going to violate transparency with our commitment to communities. It's going to disproportionately harm populations at risk for the worst effects of COVID-19, which is going to violate our commitment to equity. It's going to lead to worse outcomes, which is going to break trust. So people can't use the info because it's not clear. They're not going to use the information well. So for example, they're not going to use it well enough to protect themselves. People said, you know, it has to have alcohol. And so there's a great story that, you know, Tito's vodka came out with a statement saying, our vodka is not an appropriate hand sanitizer because the alcohol content is not high enough. Tito's vodka was doing a better job of informing the public about what was necessary for adequate hand sanitizer than a lot of public information, a lot of public facing health information. And so it's concerning that people get information, but it's not enough information to use to protect themselves well. And I say breaking trust, but really we know that so many populations in this country have justifiable concerns about the medical community. My department hosted a wonderful public reading of a play developed from the Tuskegee experiment. And we still had African-American audience members saying, we're still concerned that we're being treated like guinea pigs by the medical community. We're still suspicious of how we're being treated. And there's obviously ample evidence that certain people, certain segments of the population are disproportionately disaffected, for example, by the pain medication administered during a hospital stay. And so it's not just about breaking trust, it's about not rebuilding, not maintaining, not overcoming some trust that's already been broken. So what do we do about it? How do we address these ethical concerns with health communications during COVID-19? Well, I know I'm preaching to the choir here, but I want to review some. And some of these have been discussed today very, very clearly. So I won't go into any detail. But I think some of the things that we discovered in our brief research into COVID-19 public-facing health information would suggest stating the purpose of the document clearly up front, making sure that people know what information, what the information they're getting is intended to do for them. Using plain language. And something that hasn't been mentioned that much in this conference is the notion of high frequency words. So apparently there are some formulas that would highlight some words that are not plain language, but that are not very often used, but they're, you know, say short syllables, but they're so rarely used that they might not be understood. There are also words that have larger, you know, a larger number of syllables, but that might be high frequency, that might be common enough that people would understand them. So for example, you know, with the word education, 4 syllables, we might say, well, on some recommendations, that'd be too long, but anyone with kids tends to know what the word education might mean. And so recognizing the audience that you're writing for and recognizing which words are high frequency words, because the one concern is not alienating your audience by infantilizing them. You don't want to use 2 words. We, in our shop, we had used the word pee instead of urine in some cases, and our focus groups just found that insulting. That's like, look, we know what urine is. You don't have to say pee. We're not 5 years old, right? And so it was interesting that many of our focus group participants were sort of concerned about the terms we were using. So we have to be very careful about, even when we're trying to use plain language, that we're not alienating or infantilizing the populations we're trying to partner with and build trust with. Of course, explaining jargon and using shorter sentences and chunking information, creating ample white space, making sure the organization tracks eye movement in a way that's intelligible and usable. The appropriate use of numbers, using frequencies instead of probabilities, presenting numbers visually, again, something that the COVID-19 public-facing health information didn't do. You know, using icon arrays to identify the risks of certain populations that might be higher risk than others. Using visual aids to guide understanding and actionability, and identifying clear step-by-step instructions. And you know, I really appreciate the work that Corinne and Ariana did with the Communicate Health presentation. If you didn't get a chance to watch that, it's worth going back and looking at it. Lots of good tips and techniques for employing health literacy interventions to address some of these ethical concerns. Same with Barbara Kingsley from the Center for Plain Language. Really appreciated that presentation today. And, you know, so much of health literacy really is aimed at addressing ethical concerns. I think any of these we use, you know, using active voice, using teach back or transcripts when we're presenting video information, visual health literacy tools like using alt text and making it friendly to e-readers. And I apologize that some of these, the images on my slides are using text boxes, which, you know, was brought to my attention during this conference, that text boxes mess up e-readers. And so, you know, it's something that we can all learn from. But using standard health literacy interventions. But I think public health ethics also has a nice contribution here. And I think one of the ways that we can help populations who might be at higher risk for contracting and experiencing the disproportionate effects of COVID-19 are creating some templates that can be used to disseminate information quickly, identifying commonly needed health information. Commonly needed health information is going to differ depending on the community you're addressing. And so I appreciate the advice from multiple presentations to engage in audience research, finding out what concerns your audience has and addressing them. So concerns about rights that was brought up by Barbara Kingsley today is important, right? Because the populations that we're dealing with, that we're addressing, they have concerns that we might not have thought of as the health community. And so it's important to get insights from the audiences that we have so that we organize information appropriately, so they don't write it off, or they don't worry that it's overly politicized. And there's a tool, someone had asked in one of those presentations about a tool for focus groups, and Christy Haddon in 2017 has put together a really nice stoplight coding program that we use at the Center for Health Literacy at UAMS. It's worth looking at. And those templates can be vetted for health literacy standards. So we can have standardized language for how viruses spread, and whether the viruses have fomites associated with them that we could translate into plain language. Whether we can have a collection of resources that are standardized for where to go for reliable information that we can include in our public-facing health information. We can pair this information with graphics that have already been vetted for health literacy information, or sorry, health literacy standards, so that we can pair them together when we're creating new templates and when we're adapting templates for new public health information. And all of these can be swapped in and out and adapted in line with our guidelines for health literacy standards and depending on the public health emergency. But the idea is that it allows us to very quickly put together information and update information that's already been vetted for health literacy standards. Another practice I think would be useful is to cite, explain, and admit. So when we're creating or adapting our templates to new public health emergencies, we make a commitment to using quality sources and consensus information, that we're consistently applying and using evidence-based information, and including a why when appropriate. Again, we know that health behavior change is complicated, and it requires buy-in, and people have to believe that they're at risk, and people have to believe that the risk is a big deal, and people have to believe that whatever advice is being given will actually protect them. If it's with respect to masks, they have to know that they're not going to have trouble breathing, or they're not going to suffocate. And so making sure that you're helping them buy into the information by including the why when it's available. And if information is vague because of uncertainty, make sure that we're being transparent about that, that people need to check back for updates, that people can, that have reliable sources to go back to turn to for updates, and to be transparent that we're still learning, that even the experts don't have the full story yet as public health emergencies develop. And then finally, a point that I think has been made a couple of times during the conference is to partner with the community, both for learning what information is commonly needed for certain populations we're engaged with, but also the concerns that are raised by those populations, and for the building of trust with with populations. So when individual liberties are threatened, for example, we need to start by addressing the perceptions associated with those, as Barbara Kingsley pointed out. And we need to spread that information through those channels of trust. Not everyone has access to the internet, but they might still have a robust church community. And I really appreciate Ernesto Wright from the Green Foundation pointing out the importance of hair salons and barbershops to the African American community. These are places where there are already communities of trust. And if those communities accept the health information, then that's one way. If we can partner with those communities, then we can help address demographic obstacles in getting information out quickly, and accurate information and timely information, and information that addresses the felt needs of the community. And finally, if we have the ear of our state officials, one of the things about working at UAMS is that there are a lot of people because we're a state institution, are working with our Arkansas Department of Health. And if we have our opportunities like that to help work with state officials on crafting messages, to make sure that the messages are accessible in the languages they need to be accessible in, making sure that they're addressing the needs of the community, make sure that they're vetted for health literacy standards. If we have opportunities like that, we take advantage of them. And I think these help address some of the ethical concerns with respect to trust, transparency, and equity. Now, there are a number of other ethical concerns I could raise with respect to health literate writing and visual presentations and oral presentations. I'm happy to talk about some of those, but they include things like how we frame information, positive versus negative framing of information, avoiding ordering bias in the information that we present, or at least appreciating its effects on how information is perceived. Avoiding scare words. In the clinic, as a clinical ethicist, one thing that we try to avoid using words like futile, because futile has a lot of different meanings for a lot of different populations. And so rather than using the word futile, we use something else. The words terminal have very different meanings in the medical community than necessarily from the community at large. And so words that scare people before they've had a chance to process information. Avoiding morally loaded language that can incite shame or guilt. Recognizing all the ways that our language nudges people, for good or for ill, can help us create and craft language that benefits the community, and rather than alienating them or instilling more distrust or concern about inequities. So there are my references. I want to thank you for your time. I'm happy to talk, to answer some questions. We are about 15 minutes for the top of the hour, so I'm happy to talk with you about, to answer some of your questions here. What do you say about the use of militaristic combat language used by a number of states declaring war against the pandemic? What do you think of the ethical implications of using war metaphor to describe state response to pandemic? I think it's a great question, and I think it's a concern throughout medicine. I had a medical student who was trying to do some research on the use of metaphors, of war metaphors in cancer patients, the survivor metaphor, the fighter metaphor, and I think these all influence the way we think about and respond to medical advice and the expectations that society places on us. And so, yeah, it's concerning, and it's interesting. Like there are centers that are like the Cancer Survivor Center. So they're built into some of the infrastructure of medicine, and I think that's the tendency. The tendency is to use war metaphors because it feels like we're doing something. And that's, I don't quite know how to address it other than to ask people to stop using them. I think that it's difficult once you get an issue as politicized as COVID-19, that it's difficult to pull politicians away from metaphors and terminology that gets people's attention. But I think working with medical providers and health communicators, I think we can help stave off some of that. But yeah, it's a concern. Have you tried using co-metrics for readability assessment? No, I'd be interested in trying that. Thank you for the recommendation. We'll look into that. Did you or have you looked at apps as well? Most use digital apps and smartphones. That's a great question. We actually have some people at UAMS working on digital health, and we have vetted some online materials in the past for mental health. We have not vetted app-based information. Now, that'd be something worth looking at, absolutely, for sure. We'll be publishing that study of online COVID materials. Absolutely, yeah. It's actually coming out in Frontiers in Health Communication, or Frontiers in Communication. It's been accepted provisionally for publication there. Where can ethicists go for training on how they can use more, sorry, this is bouncing around a little bit, more plain language practices in their work? That's a great question, and it's, I don't know of many. I published a paper in HEC Forum on the relationship between health literacy and ethical practice in the clinic. And so I give some guidelines in that article, but I don't know that there are specific training outside of just going into say a plain language certificate program or a health literacy certificate program that are aimed at ethicists. Can you tell us a little more in your closing statement about being conscious of the ways our words nudge people? Absolutely. So there's a phenomenon, our field of study called behavioral economics that arose out of economics and psychology. And it's been sort of known as the nudge movement because of the work of Cass Sunstein and Richard Thaler. And the idea is the way that we present information involves a choice architecture. We're automatically, anytime we present people with choices, we're presenting them in a way that is going to be interpreted in certain ways by them. And advertisers do this, and health providers do this. Anytime you're presented with choices, that choice has an architecture or a structure to it. And it turns out that even when the content doesn't change, if you change the structure, it changes people's behavior. And these are called nudges. And the nudges are so it's the non-content related structure that affects people's behavior. And so I used to give this example when I was talking with students in basic ethics classes. I would say, imagine two questions about abortion. Imagine if you started with the question, is any abortion ever morally permissible? And then asked, what about in cases of where the mother's life was in danger? Right? And I said, regardless of how you answered that question, it seems like you might have more nuance once you got the second question. You might have more to think about. Your moral imagination was expanded. But imagine if I flipped the question. If I said, is abortion permissible in cases where the mother's life is in danger? And then asked, is any abortion morally permissible? It might change your answer just because of the order. Same questions might change your answer because your moral imagination has been expanded a little bit. And this happens with lots and lots of questions and choices. And so being able to recognize the ways in which our language affects people's responses. One of the most common examples is whether information is presented negatively or positively. If we say, look, you've only got you've got a 20% chance of dying from this versus you've got an 80% chance of living from this. That can affect the way people interpret that information for their own behaviors. So I hope that answers that question a little bit. How would you say the use of patriotic language has been impacting COVID? That's a great question and a little bit difficult to answer. I don't have information about how it has affected it. I do concern that it adds an additional layer of politicization to it, which again, as health communicators, we're trying to address people at their health needs, not at their political needs. And we're trying to avoid certain red herrings when it comes to their political needs. And so the next question, do you have more ideas on how we can depoliticize the fight against COVID-19? I think that, the information, like the strategies recommended by Barbara Kingsley, for example, about addressing people's felt needs first, recognizing the audiences that we're engaging with, and making sure that we're addressing those needs first so that we improve our transparency when we're communicating information, can help depoliticize it to some degree. But as we know from evidence on, research on political ideologies, it's going to be very difficult to depoliticize anything when the state is already involved in making recommendations and restricting certain types of public behaviors. All right, I'm not going to be able to answer all these. I really appreciate all these questions. I hope I'm doing justice to some of them. Uh, Let me see. What are your thoughts on not addressing mental health during a public health emergency? So many people rely on city and county services to address their mental health needs. Too often, mental health takes a back seat during a crisis. I 100% agree. And I think that, again, this is part of our commitment to transparency, recognizing the increases in mental health problems for people who live alone and for people who are experiencing increased amount of intimate partner violence, emotional abuse, children who are caught in the middle of this, children who are not in school, so they're viewing more of this than they've ever viewed before. And so I think that, again, part of the transparency is there are the trade-offs for, say, restricting, closing down certain businesses are non-negligible. And I think we need to be transparent about that, and that it really is about trading off values when we're making public health decisions. And we need to be able to offer people alternative sources of help for mental health opportunities during this time. How do you find the balance of framing of wearing of masks as showing that you respect and care about others while not honing in on feelings of guilt and shame for those who aren't wearing them? That's a great question. I think it's hard to answer too, right? Because we're so concerned to get people to wear masks, and for good reason, that there's a byproduct of that. And the byproduct is the people who don't, or think that they have good reasons for not wearing them, are going to feel maybe more defensive, maybe shamed, maybe guilted. Yeah, I would really be interested in ways of addressing some of those concerns. How we could frame information about mask wearing that doesn't do that, that doesn't have that effect. Not because don't think those people should feel some pressure to wear masks, but it's the wrong kind of pressure, right? It's the kind of pressure that alienates and breaks trust rather than builds trust. And so one distinction I draw is between autonomy empowering nudges and autonomy shutting down nudges. So nudges that do the work behind the scenes shut down autonomy, whereas nudges that do the work up front are empowering to people. And so I think if we could dig into some of the details of how nudges work, then we might be more sensitive to the ways that our framing affects people with respect to guilt and shame. But I think that's going to take some research. I'm not sure we're going to be able to do that sort of from our, from our desk chairs, from our armchairs. I think we're going to have to kind of dig into where those motivations are coming from and figure out language that helps diffuse some of that. Do you have ideas for how, let's see where we are. We got, yeah, about 6 minutes left. Do you have, oh no, sorry, we got a 3:50, right? So we're a little bit over time. I appreciate this. I will address this last one. Do you have ideas for how hospitals can share information about the change in visitor policies while still recognizing the value of families as partners in care? I gotta say, this has been one of the most difficult questions to answer as a clinical ethicist who is trying to participate in with my hospital's administration, both at the adult level and the pediatric level. To communicate clearly with families that this is not a devaluing of them as partners in care, but a necessity based in, sort of evidence-based necessity. And so the question is really going to be, how do we adapt our practices to not just tell, but to show how we're still valuing their participation as families, as in partners in care, right? So at our children's hospital for a while, we had a one visitor policy. That meant typically the mother. And so the father was left out, and there was lots and lots of animosity that has arisen from that. And I think rightly so, because we didn't think far enough in advance about how to address that concern in a way that was, in a way that built trust with that family, right? We said, oh, we're in a public health emergency. This is the policy we have to have. You're just going to have to accept it, and we'll definitely include you in conversations, but only one of you can see your child. And so I think we've got to work harder when it comes to that sort of information, and not forget that people are they have perceptions about who we are as an institution when we make decisions like that without including them transparently in the process. One idea, somebody says, suggest other family members call in or FaceTime during visit. Absolutely, and we've certainly done that. We've definitely made use of all the technology we can make. But of course, obviously, family members want to touch their children. They want to be there present. And so anyway, thank you so much for your participation. I really enjoyed this opportunity to present. Thank you again for this wonderful conference. And I hope these questions and comments are going to be saved. I'd love to read through them. And again, the PowerPoint's available for you on the handout section on the agenda.